Live from Boston, I'm Emilio Madrigal. Today is Cinco de Mayo 2020, and I am joined by my colleague and friend Rifat Manan, based out of Philadelphia at UPenn. It's been a while since we hosted a GU Path on Pathcast, and what better way to bring it back than hosting Dr. Anil Parwani. Dr. Parwani doesn't really need an introduction, but I'll do one anyway. He is a professor of pathology at Ohio State University, and he specializes in genital urinary pathology. And as most of you probably know, he's also a driving force in the field of digital pathology. Today, Dr. Parwani will be presenting a talk titled A Practical Update on the Classification, IHC, and Molecular Pathology of Urothelial Neoplasms. As always, please post your comments, questions in the Facebook and YouTube chat windows, and we will make sure to bring those questions and comments up at the end of the session. So with that, I'll just pass the microphone over to Dr. Parwani.
Thank you, Emilio. Thank you for the introduction. Good morning, everyone. Today, I'm going to talk to you about bladder cancers. I'm going to talk to you about classifying them using immunohistochemistry and what do we know about the molecular pathology of these tumors. So I'm going to give you some practical tips on what I use at my sign out. So I'm going to talk to you about what is the current understanding of the molecular pathology of ureteral carcinomas. We will talk about the 2016 WHO classification. I'm going to give you some examples of some of the more common variants and some uncommon variants of bladder carcinoma. And how do we use IHC in diagnosis and classification? If your IHC lab is closed for the day and they can only do 2 immunostains, which 2 immunostains will you use judicially to make an impactful diagnosis? So urothelial carcinoma is the most common tumor of the urinary bladder, and it has a propensity for divergent differentiation, with the most common variant being squamous and next is glandular. And it's critical to distinguish glandular from the adenocarcinoma of the bladder, which are very rare. It's important to recognize these variants because they can mimic benign lesions such as cystitis cystica, inverted papillomas, paragangliomas, nephrogenic adenomas. And we are uncovering new molecular data, which is providing additional insights into what these morphological subtypes really mean and what are the associated genetic alterations. In terms of 2016 WHO classifications of tumors of the urothelial tract, if you look at urothelial tumors, we can subdivide them into infiltrating or non-invasive. So if you look at the infiltrating ones, some of the more common ones are nested, microcystic, micropapillary, lymphoepithelioma-like, plasmacytoid, rhabdoid, sarcomatoid, and some more rare giant cell, lipid-rich clear cell. If you look at the non-invasive ones, we have the carcinoma in situ and the low-grade and the high-grade carcinomas, papillary. And then we have papillary urothelial neoplasm of low malignant potential, this is the category that I rarely use in my practice. But then you have urothelial papilloma and inverted urothelial papillomas. So let's focus on the non-invasive urothelial carcinomas, including CIS, low-grade, high-grade, papillary urothelial carcinomas, low malignant potential, urothelial papillomas, and inverted papillomas. And the more common ones, infiltrating ones, as I mentioned, are nested, microcystic, and micropapillary. So if you look at the classification of these tumors and the T staging, it's easy to think about them as either in situ or invasive or papillary in terms of the grading. So if you look at the 1973 WHO classification and the 2004 WHO ISUP, where we subdivided this into low grade and high grade, you can easily separate the two, the non-invasives and the carcinoma in situ, across this line. So the non-invasives are, urothelial carcinomas are subdivided in this category, and invasives are subdivided in this category. So as an example, if you look at this photomicrograph, which shows early invasive urothelial carcinoma, which is superficial disease PT1, you can see this nest of invasive carcinomas which may create a desmoplastic response. And if you look at higher power in this screen, in this, you can see there may be some retraction artifact here. The other critical thing that we want to convey to the urologist is this tumor invading the muscularis propria? So here you can see some examples of true muscularis propria invasion. So you want to look at thick bundles of muscle as the tumor invades into these muscle bundles. So let's talk about what do we know about the molecular pathology of urothelial carcinomas. So very simplistically speaking, if you look at normal urothelium, and you have to look at the urothelium in the context of what the normal cells around the urothelium look like. So if you look at the normal urothelium, there are three possible pathways: hyperplasia plus dysplasia, and CIS or dysplasia. And they have distinct molecular changes. So you have the group of tumors which are papillary carcinoma low-grade TA. Majority of these tumors have mutations, like greater than 60% of these tumors have FGFR3 mutations or overexpression, and they have a mutation in RAS. So clinically, these tumors, these patients come back with recurrences. Some of these will progress to high-grade papillary carcinomas, and those can also keep recurring, or they can advance to the CIS stage, where they now are from genomically stable to genomically unstable. And some of these tumors can also go down the dysplasia pathway or the CIS pathway, where they have P53 deletions or mutations. They have RB deletions or P10 LOH 30 to 35%. A subset of these tumors, either coming from the hyperplasia pathway or from the dysplasia pathway, will become invasive. So this is critical because as we understand more and more about the genomic landscape of bladder cancers, we can start to think about different clusters in urothelial carcinomas. So this is the gene expression profiles of a large subset of urothelial carcinomas, and they can be divided into clusters. So clusters 1 and 2 are enriched in tumors with papillary morphology. So these are tumors where your patient will present with a papillary tumor in the bladder. These are tumors which have frequent FGFR3 mutations. They have copy number gains in FGFR3, or they have high expression of these proteins. All these patients also have significant lower expression of microRNA 99A and 100. And it's similar to if you are presented with a patient with breast cancer, possible match to the lymph node, they have a luminal breast-like tumor profile, which is GATA3, FOXA1, ERBB2, like HER2, and they all express uroplakin-3. You can distinguish this from cluster 3, which is more basal and squamous-like. Expression of basal-like phenotype markers, expression of KRT, KRT5. So this picture shows you basal types of bladder carcinomas, which have strong CK5, CK6 expression, cytoplasmic. They have a CD44 staining, which is membranous, and they have P63 staining, and they have a membranous staining with EGFR. In contrast, the luminal type of bladder cancers, they have a staining pattern which is strongly positive for cytokeratin 20. Some of them are staining with CARA3, very strongly positive, and then membranous positive for uroplakin 2, and ERBB2 staining, membranous staining. So if you look at how can we look at bladder cancer, some of them stain with CK20, some of them don't. It's best to classify them as luminal markers or basal squamous markers. So majority of them are luminal, and if you subdivide the luminal, they can be luminal papillary, luminal infiltrated, luminal, basal squamous, neuronal. So this has a huge impact. So as a GU pathologist, or even as a general pathologist, it's important to note down these morphological phenotypes because they have implications for therapeutic. So we have FGFR3 inhibitors. Patients can be treated with early cystectomy. They can be subjected to immune checkpoint therapies. They can have different types of therapy depending on how you sign out the case. And deep down, we really need to, like instead of calling it invasive urothelial carcinoma, try to sub-distinguish it as much as you can, especially the high basal squamous phenotypes, because they have different types of therapies. So with this, I'm going to talk about some of the glandular lesions of the bladder. So this includes cystitis cystica, nephrogenic adenoma, Mullerianosis, villus adenoma, non-urethral adenocarcinomas, urethral adenocarcinomas, and clear cell adenocarcinomas. So this is an example of a nephrogenic adenoma. So you can see some of them can have almost an appearance of a papillary ureteral tumor. But the key thing to notice is that they have a single layer of cuboidal cells, or they can have these tubules. And if you're looking at a prostate patient, male patient with a history of high PSA, these can mimic prostate cancer, these tubules. But this is really a benign mimicker of prostate cancer. So this is an example of a nephrogenic metaplasia or nephrogenic adenoma. You have these tubules. They look pretty atypical. If you look at this nucleus, they are very, very atypical looking. And I've seen these being called adenocarcinomas. But the key thing is look at the inflammation in the background. Look at all the plasma cells, look at all the lymphocytes. And most often, these patients have a history of repeated instrumentation. So these lesions will stain strongly with CK7, and they will also stain. So this is an example of a papillary subtype of nephrogenic adenoma. So these will also stain with Pax8. These will also stain with Amicar. So another example of a nephrogenic adenoma. The key thing to notice is that there is a single layer here. Let's talk about the adenocarcinoma of the bladder. So there are two general types of adenocarcinomas in the bladder, those which arise from the urachus, which is approximately 1/3, and those arising from the bladder itself, which is approximately 2/3. There are several morphological patterns that you can see, including enteric, or most commonly, the one patterns that I often see are NOS. They can look like anything. They can look like colon cancer, they can look like prostate cancer, they can look like signet ring. So the key thing to remember is in the bladder adenocarcinoma world is most bladder adenocarcinoma are from metastatic sources. They are either extension from an intestinal adenocarcinoma. So I always put a note in my diagnosis that it's critical to distinguish and to critically evaluate the patient's history and look for any other sources of the adenocarcinoma. So if you see an adenocarcinoma in the bladder, it's most likely a metastatic process. So just like the GI tract, you have villus adenomas in the bladder. These are benign. These look histologically identical to colorectal adenomas. They have a below glandular architecture. You have fibrovascular coats lined by pseudostratified columnar epithelium, and they look just like a colon villus adenoma. So primary bladder adenocarcinoma is very rare, less than 2% of bladder malignancies, and you generally see them in older patients. Most commonly, these patients will present with hematuria. Prognosis is poor, and the survival rate varies from 18 to 47%. So this is an example. In contrast, this is a invasive urothelial carcinoma with glandular differentiation. So this is not an adenocarcinoma of the bladder. So the key thing to look for in these patients is not to call this bladder adenocarcinoma, is to look for an in situ component. Look for features that you would normally see, like apical cytoplasm, more basally situated nuclei. Testing is, you can do immunostains, but oftentimes they overlap with adenocarcinomas. And these tumors, adenocarcinomas, can be CK7 positive. They may also be CK7 positive. They may express villen, just like they have colon adenocarcinomas and CDX2. Some of the studies that have been done so far show that these tumors do not express nuclear beta-catenin. So if you look at this photo micrograph, you can see most of the staining in this primary bladder adenocarcinoma is cytoplasmic. The nuclear staining is 0. So that's a soft feature. I sometimes do a beta-catenin to distinguish these primary adenocarcinomas from colonic adenocarcinomas. So these tumors can have, this is an example of a primary bladder adenocarcinomas, enteric type. So they can look like colon cancer, well-formed, malignant glands back to back. They can have a mucinous background. They can have signet-ring cells, like you can see here in this photomicrograph, and these in the pools of mucin. They can show strong staining with CK20, and they can show strong staining with CDX2. So they're indistinguishable in IHC profile from a colonic adenocarcinoma. This is a membranous staining pattern, and again, note negative nuclear staining with beta-catenin. So this is a study that was just published 2 years ago, where a bunch of bladder adenocarcinomas were sequenced by Dr. Roy. So they looked at genomic profiles of 25 high-grade urothelial carcinomas and 25 colorectal adenocarcinomas using next-generation sequencing. And of these, patients predominantly were male. Their average age was 66, and they had different subtypes, including enteric, mucinous, signet ring, or mixed. Majority of them had a high T stage, T4. So if you look at conclusions from the study, was that they have substantial overlap with colorectal adenocarcinomas in terms of genomic changes. 11 of the 15 cancers showed at least one genomic alteration in P53, KRAS, PIK3CA, APC, IDH, many of which are novel. So even though they have significant overlap with colorectal adenocarcinoma, there are some unique differences. So if you looked at all the cases that were sequenced, majority of them had missense mutations in P53, a stop gain mutation in KRAS, and more rarely RB1. So this is an example of one of the cases from the study where you have CTNNB1 and APC mutations. These were restricted to enteric subtype only. This is a small study with 15 cases, but that's a huge, because if you look at these nuclear beta-catenin, you can see strong positivity in these patients, and some nuclear negative beta-catenin. So in addition to that, there was lack of genomic alterations in the mucinous subtype of bladder adenocarcinoma. So going back to our original chart, if you look at FGFR3 and HRAS mutations, all these were mutually exclusive between primary bladder adenocarcinoma and high-grade urothelial carcinoma. So I'm going to now talk about a case from a 34-year-old man who presented with abdominal pain and dysuria. A CT scan was performed, and it revealed a small nodule on the dome of the bladder. Cystoscopy was done, and it demonstrated a 2 to 3 centimeter tumor at the bladder dome with some purulent discharge, and a partial cystectomy was done. So this is what we received in the gross room. So you can see a glandular exophytic lesion, which is about 1.5 centimeter. If you look at the H&E slide from this lesion, this was protruding from the mucosal surface of the bladder wall, and it had intestinal type epithelium. So if I showed this to you in the GI service, this looks like a intestinal type epithelium, right? So this could be a villus adenoma, this could be metaplasia. If you look at the lamina propria underneath, you can start to see a desmoplastic reaction. And this is in close proximity to the lesion. You can see here, this is a bladder wall, is an epithelial line, dilated cystic space. And if you look at it higher power, you can see a desmoplastic reaction that extends through the muscle. You have these small glandular structures, and even in the fat, you have these atypical cells. So higher power, you can see this looks abnormal, this looks atypical. So this should prompt you to think about, is this invasive cancer? As you look at the muscle and the deeper bladder wall, you can see a lot of this activity here around the muscle bundles. If you stain this with a keratin stain, you can start to see single glandular structures in the muscle, adjacent to the muscle, in the fat. So this is a ureteral adenocarcinoma, which is associated with a villus adenoma. So the key thing to take home is that when you see a ureteral lesion and it looks very much like a villus adenoma, it's critical to go back and sample the lamina propria and the muscle and the fat extensively to look for invasive component of this ureteral neoplasm. So ureteral adenocarcinomas are primary. They're very rare. Blood hematuria is most common. You can have partial or radical cystectomy with embolectomy. Last week, I had a case where there was a question of ureteral adenocarcinoma, but it really turned out to be carcinoma in situ, arising in a ureteral remnant. So let's talk about some examples of invasive adenocarcinoma. So as I mentioned before, this is the current WHO classification. These are the subtypes. So I'm going to show you some examples of this. But the key thing I want you to understand is urothelial neoplasms, invasive, have a variable appearance. Now, they can look like anything. So it's a very challenging diagnosis, especially in metastatic setting. So last week, I had a patient with questionable lung cancer, but it turned out to be urothelial, mats from the urothelium, and that was the initial presentation. So some of the variants that we commonly see include micropapillary variant, which is a variant which you have fine papillae, very, very high-grade cytological features. There's oftentimes necrosis. The key thing to notice is that you have a traction artifact with these tumors, which simulates lymphatic spaces. So it looks like this is this lymphovascular invasion. So Most residents who preview this case for me, they call this lymphovascular invasion, but it may not be. So this is an example of a micropapillary variant of urothelial carcinomas. The key thing we have beginning to understand is that high frequency of these will have HER2 mutations. And so this raised the possibility of targeted treatment using ERBB2 inhibitors. So a high power view of a micropapillary variant of urothelial carcinoma. These spaces are lined by, like focally spindle cells or maybe devoid of any lining. But the key thing is, if you understand this lacunae of micropapillary urothelial carcinoma may mimic lymphatic invasion. So you don't overdiagnose a lymphovascular invasion. The key thing is about 2/3 of these patients will present with lymph node metastasis. So high power view of a micropapillary variant of urothelial carcinoma invading into muscle bundles. This is another variant which I want to highlight is the nested variant. So these look very bland. They have a very deceptive, irregularly invading muscle fibers. As you look at higher power, you can appreciate the cytological atypia. You can appreciate this, particularly in the deeper portion of the lesion. So don't be fooled by the nested variant, because most nests have a very bland cytological appearance. But look at the cytological complexity, look at the confluence, look at the anastomosis between nests, which are features that will help you distinguish carcinoma from benign one-brood nests and often benign conditions in the deeper portions of the neoplasms. So the other variant that I want to call upon is a lymphoepithelioma-like variant. This is the hallmark of this lesion is a prominent lymphoid infiltrate, which is an admixture of inflammatory cells or plasma cells, or rarely you can see eosinophils in these. So the lymphoepithelioma-like variant have, in few series that have been described, they have very rarely can you see this tumor in pure form. They are more responsive to systemic therapy. They provide potential to salvage the bladder function, but they're oftentimes mixed with other subtypes. So the point is, high-grade carcinomas of usual type should not be termed lymphoepithelial-like because of brisk infiltrate. You really need to see a substantial, prominent lymphoid infiltrate to call them lymphoepithelioma-like variant. So this is an example of bladder cancer with lymphoepithelioma-like features. So you can see very large cells with a vesicular nuclei surrounded by an infiltrate of inflammatory cells and lymphocytes, predominantly lymphocytes. If you stain this with keratin, you can see the very large cells are staining with keratin, but the lymphocytes in the background are not. So with this, I will pause and I will talk about how can we utilize immunohistochemistry. So IHC has a value in bladder cancers, and there are some applications. So the key things when I order immunostains or when my residents order immunostains are to help differentiate reactive urothelium from carcinoma in situ or dysplasia, and to help confirm urothelial site of origin versus other primary tumors. So how can we use IHCs for this purpose? So if you wanted to differentiate reactive urothelium from carcinoma in situ, the key things to remember is this panel of immunostains can be helpful. You can use this to separate reactive from carcinoma in situ from normal. So if you did CD44S, this is usually negative in urothelial carcinomas, or only basal cells are positive. In a reactive pattern or a normal pattern, you can separate this out because you will see transurothelial staining with reactive urothelium or only basal cell staining. CK20, I think, is the most important marker. Normally, it only stains umbrella cells in normal urothelium, and it's negative in reactive urothelium. But in contrast, in urothelial carcinoma in situ, you have a strong staining which is transurothelial in urothelial carcinoma in situ. Again, you have to remember that it really boils down to what are the molecular changes in these patients. Is it a luminal subtype? Is it a subtype that stains with CK20 or not? But in general, we use this CK20 as a marker, as a surrogate marker, to differentiate from neoplasia versus dysplasia versus normal. P53 is often strong in CIS and very weak in reactive and normal. And Amacar is surprisingly a good marker because it stains strongly CIS or even dysplasia, but does not stain reactive or normal. And then more recently, we are starting to see studies where HER2/neu is used as a marker to use the strong transureteral staining. But in the reactive and normals, you just see strong luminal or weakly basal staining. So this is an example of a staining profile where you can see strong staining with, if you look at, this is CIS, and you can see strong staining with CK20 and P53. This is a combination stain with CK20 and P53. So on the left-hand side, you can see strong staining with P53, which is the red stain, the nuclear stain, and strong cytoplasmic staining. Notice it's transureteral. In contrast, there is no P53 staining and only umbrella cell staining in the right-hand side, which is a reactive or normal pattern. So if you look at this stain, if you look at this H&E slide, if you were my residents, I would ask you, what is this? Is it reactive? Is it cancer? And if you did a stain, you can see majority of these umbrella cells are staining, but it's not a transureteral staining pattern. So this is reactive. In contrast, you can see this is a carcinoma in situ, where you can see the nuclei are huge, and if you stain this, you can see strong transureteral staining with CK20 and strong P53 staining. So I often use these stains to distinguish neoplasia from reactive. So the other reason why we use immunohistochemistry in bladder cancer is to confirm the site of origin. So oftentimes, if it's urothelial carcinoma metastatic in the liver or the lung, they will stain strongly with P63. They will stain strongly with high molecular weight cytokeratin. They will stain with CK7, and up to 50% of these will stain with CK20, and CARA3 is positive. So the key marker that we use is CARA3, which is a nuclear marker. It's positive in urothelial cancer and breast cancer, but it's negative in prostate and squamous cell carcinoma, usually. So when you are confronted with a patient who has a metastatic lesion, has some history of bladder cancer, is CARA3 positive, the only key cancer to distinguish it from is breast cancer. So I often include ERPR or hemoglobin in these patients to separate it from breast cancer. The other reason why we use immunos in bladder cancer is to separate bladder cancer from prostate cancer, because poorly differentiated tumors can look like bladder or prostate in that setting. So I will always use two markers. I don't use a single marker. For bladder, I rely heavily on CARA3. So this is an example of a prostate versus bladder cancer. We can see tumor cells are positive for P63, which is a basal cell marker for prostate cancer. It's staining for high molecular weight cytokeratin. Again, these two stains should not stain in prostate cancer. And then they're staining with KERA3. So this is bladder cancer. So let's do a case. This is a 62-year-old who presented with hematuria and had a bladder mass and was subjected to a TURB procedure. So you look at this tumor, you have almost looks like cystitis cystica with high-grade urothelial carcinoma. If you look at higher power, this looks like urothelial cancer. So if you were working this up, many of the pathologists I work with may not even stain this. They may call this ureteral carcinomas, and I'm sure the audience who is listening to this today, they will feel the same way. Why do immunostains? It looks like ureteral carcinoma, right? But if you look at high power, you notice the pinpoint nucleoli. So this looks very unusual for a bladder cancer. Bladder cancers can have nucleoli, but uniformly distributed in this field. And if it's a male, you should think about, is this prostate cancer mimicking as bladder cancer? Even though you have pleomorphic nuclei, which is rarely seen in prostate cancer, you should still question your diagnosis. So I have been burned a few times because of, buying into the morphological appearance of the tumor and not questioning the diagnosis of prostate cancer, either extending into the bladder or metastatic. So if we were doing a poll, I'm going to ask you, what's your diagnosis? And if you look at the stain, this is the NKX 3.1, which is a prostate marker. So this is prostate adenocarcinoma, which is mimicking as a urothelial carcinoma. This is strong PSA staining. So let's do a couple more cases, and then I'm going to stop for questions. Okay, so this is a 47-year-old female with hematuria, bladder mass, and subsequent urinary bladder biopsy. So this is the HLA slide. You can see at this power, at low power, you can see some clear cells, and you can see some papillary structure, some cystic structures. At higher power, you can see single lining, which is more cuboidal looking. You can see some mucinous or mucoid stroma. And higher power, you can see more large pleomorphic nuclei, some large cytoplasm, and very solid growth pattern. Some of these nuclei have prominent nucleoli. They stain strongly with CK7, strongly with PAX8, and you can see an unusual, you can see the normal reactive urothelium is not staining with PAX8, but this lesion is staining strongly with PAX8. So you can see the transition from normal to neoplastic. Strong staining with Amacar in the lesional cells. So this is clear cell adenocarcinoma. So this is really fairly rare, but this is an example how you will encounter these lesions. So clear cell adenocarcinoma of the lower urinary tract is uncommon entity arising from the bladder and the urethra. Female predominance, hematuria and dysuria. So the key thing is the neoplastic cells have a glycogen-rich clear cytoplasm with enlarged hyperchromatic nuclei, irregular nuclear contours, and coarse chromatin. And it's also been, if you search for this in PubMed, you can use the term mesonephric adenocarcinoma. The second case I want to present to you is a 57-year-old with hematuria. Ultrasound showed a bladder mass in the dome region, about 2.5 centimeters, and urinalysis showed a lot of blood cells, few pus cells, and all the culture cells were negative for any growth. So at low power, you can see in the TURP specimens, it looks very cellular. Go to high power, you can see clear cell tumor cells with clear cytoplasm, and they appear to, like, if you look at this looks like renal cell carcinoma or seminoma. At higher power, you can see large atypical nuclei, but they have this flocculent material in the cytoplasm, and overall it appears to be very clear. In some areas, it looks more cytoplasmic. But the key thing is, if you stain this up, they stain strongly with GARA3. So in this patient, a cystectomy was done, a partial cystectomy, and there was a bladder mass on gross examination in the dome area, which closely seemed to involve the deep muscle. So this is what you see in the H&E slide. Higher power, and it's invading into the deep muscle bundles here. So here you can see these tumor cells are infiltrating into the muscle bundles. So this is invasive urothelial carcinoma. So what do you do? What is your diagnosis? What are the next steps? How will you work up this case? So looking at this, what is the question that should come to your mind? So if you look at this, you notice that there is somewhat vascular pattern to it. There is somewhat a nested pattern to it. This is actually a paraganglioma. So this was called invasive urothelial carcinoma. And I received this as a consult. And the first thing I thought about is, can this be a paraganglioma? It's very rare. This accounts for less than 0.5% of all bladder tumors and about 6% of all extraadrenal pheochromocytomas. Within the GU tract, the bladder is the most common site. And so you're going to see this. And I've seen this very frequently misdiagnosed because of the GARA3 staining. This occurs more frequently in women than in men. So tumor may be functional. So the key thing to remember is this tumor may be non-functional or functional. With functional tumors, the patient may present with hypertension, with a headache, palpitations, hot flushes, and sweating. So if you see nested growth pattern, occasional clear cells, necrosis, and muscular propria invasion, you will think about, you may not give it a second thought. You may say, oh, this looks like invasive urothelial carcinoma, because invasive urothelial carcinomas can have a clear cell appearance, they can have necrosis, they can obviously invade into the muscle. So another example of a case. At low power, you see it looks very crowded, there are large vascular spaces. They almost look like denuded papillae. It almost looks like invasive urothelial cancer with somewhat giant cell appearance invading into the stroma, or nested growth pattern. So this looks like a nested variant of urothelial carcinoma. So at higher power, this looks like, could this be a malignant invasive urothelial carcinoma with a nested growth pattern? Even more higher power, you can appreciate the nests more clearly. And again, if you did a GATA3 stain, they will stain strongly with GATA3 plus GATA3, which is a marker for bladder cancer. So if you established the diagnosis, you were going to call the urologist, you might call this ureteral carcinoma. But if you remember, and if you knew that GATA3 staining is also seen in a subset of paragangliomas, you may think twice, and you may pause, you may order a synaptophysin stain. If you order the synaptophysin stain, it will stain strongly with synaptophysin. This tumor will also stain strongly with chromogranin A. So this is a paraganglioma. So some of the features that you see in paragangliomas can cause diagnostic difficulties and can be misdiagnosed as urothelial carcinoma. So these are some examples of urothelial carcinomas or paragangliomas, which are mimicking as urothelial carcinomas. So GATA3 expression in paragangliomas is a pitfall, potentially leading to misdiagnosis of urothelial carcinoma. So the last case I want to discuss today is a 60-year-old male with hematuria. So if you look at this, it looks very bland. Could this be cystitis cystica? Could this be bland urothelial nests, which are in the stroma? At higher power, you can start to see some occasional mitoses. You can start to see some larger nuclei. For the most part, it does have a benign nested growth pattern. So when I see this pattern in the urothelial in my biopsies, I think about, could this be a nested variant of urothelial carcinoma? And it's very difficult to make the diagnosis on a limited biopsy or a limited, very superficial TURB specimen. But here you can see a large mitosis in the center of the field. So this is the nested variant of urothelial carcinoma. So with this, I'm going to stop. Today we talked about the molecular pathology of bladder cancers. We talked about the WHO 2016 classification. We talked about some common variants of invasive urothelial carcinomas. When I look at urothelial carcinoma, when I look at bladder biopsies and TURB, I am always careful to look at the clinical history. I'm always careful to look at, does this patient have radiation? Does this patient have any additional cancer or any unusual surgeries which may make this bladder biopsy present the way it is presenting? And as you can see from some of the cases that I've discussed today, urothelial carcinomas can have a very variable appearance. They can look very bland, like the nested variant. They can look like a lymphoma, like in the lymphoepithelioma-like variant. Or they can look like prostate cancer. So you have to be really careful to look at the clinical history, look at all the findings in the bladder biopsy specimen and the TURB, and use immunostains judicially. You don't want to overuse immunostains, but you want to use them in the context of what your question that you're asking. Are you trying to distinguish bladder cancer in situ from a benign urothelium, or you're looking to confirm that it's indeed bladder cancer in a patient who has a liver mass or a lung mass? And the question is where is this coming from? So I want to thank you for your participation. I want to now open this up for any questions. Thank you.
Thank you, Dr. Parwani, for your excellent presentation. So we have a few questions that I can see. One question is, how would you classify a bladder tumor with intermediate squamous urothelial morphology, CK20, GATA3 negative, and focally CK7 and P63 positive?
Yeah, so that's very challenging because So the most important question to ask, is this a man or a woman? Is there a prior history of prostate cancer? Is there a prior history of a lung cancer? So, or is there a tumor which could be arising from the cervix or the vagina? So morphologically, these tumors cannot be distinguished very easily, and even on immunostains, it's very difficult because there is a significant overlap. So in all these cases, I rely heavily on the clinical history. I will pick up the phone, call the clinician, and ask them, do you think this is lung cancer? So no clear immunomarker that can help us separate the two.
Right. So there is another question. Are you doing molecular classification of bladder carcinoma in routine? And the very question is, which immunomarkers can be of help in molecular classification in limited resources?
So I think, we don't routinely do molecular markers right now. The only markers that we are doing for bladder cancers are maybe occasionally we'll do Eurovision, which is a FISH assay to separate dysplasia or reactive from high-grade cancers, or in the setting of, where we want to know, is this going to be a good candidate for immunotherapy? So we do PD-L1 testing on these tumors. But routinely, we do not do molecular testing yet.
So there is another question. Do you do HER2 immunochemistry and FISH in questionable HER2 always in micropapillary urothelial carcinoma?
Yes, so we are getting more and more requests from oncologists and urological oncologists who are asking for HER2 testing, and they will opt, sometimes, because we follow the same guidelines as we do for breast cancer. So if it's not unequivocal, we will defer it to FISH testing. So we have done FISH testing for HER2 in bladder cancers.
Another question is, do you use this biological/molecular classification in routine diagnosis?
Yes, so it's helpful. As very practically speaking, so some of these patients now are being put on clinical trials if they have squamous differentiation, or if they have, we are now quantitating the squamous differentiation. So if a patient is coming to our hospital for treatment, has a urothelial carcinoma, has squamous differentiation, we will quantitate it now, and we will do the usual stains like CK20 and others, but we will, urologists and oncologists want to know if there's a benefit to subclassifying these tumors because of immunotherapy implications. So we're doing more and more of this, but it's not, urologists don't really understand the implications of molecular classification yet, so it's not made its impact on daily routine practice.
Right. So another question that is, let me read it out. How often a prostate adenocarcinoma infiltrate bladder and require an immunomarker?
So it's fairly common. So of all the cystoprostatectomy specimens that I review, about 25% of these will have incidental prostate cancer. Majority of the poorly differentiated carcinomas, if you don't see a good in situ component, so if I don't see a good in situ component and I see prominent nucleoli, I will go into the patient's electronic medical record and look for any lab results on PSA. And if I don't see a PSA, I will order like a prostate marker like NKX 3.1 or PSA, just to confirm that this is indeed not prostate cancer infiltrating into the bladder. And on the flip side, you can also have in situ bladder cancer, which grows into prostatic ducts and presents as, like ductal or ductal cancer of prostate. So it goes both ways.
So next question is, in biopsy, papillary urothelial neoplasm with focal high-grade features. In this scenario, how to sign out the report and what is its clinical implication?
So you have to be very careful, because if you see, if you remember what I showed you earlier about the pathway, the molecular pathways of FGFR3 and RB and P53, if you call something high grade, that has implications for the patient. So you have to be really careful and be absolutely sure that you do see high grade. What I often do is, if majority of the tumor is low grade and I see very focal high grade features, I will call it high grade. But I will put a note that majority of the tumor is low grade, but there are focal high grade features. But for the urologists, they tend to separate these patients from purely high grade or purely low grade, because they think of this as an evolving lesion. So you have to be really very careful in not overcalling something as high grade when it's predominantly low grade.
Another question that I can see is, how much reliable P53 and CK20 in the diagnosis of carcinoma in situ?
So I would say CK20 is more reliable. In fact, in some cases, I only use CK20, because if CK20 is only staining umbrella cells, I feel confident that this is reactive or normal. If CK20 is staining, the rest of the urothelium, I feel confident that this is carcinoma in situ. You have to be careful about the subtype of the urothelial cancers you're dealing with, because a proportion of the urothelial cancers can be CK20 negative to start with. So that will not help you in separating the two. But in many cases, it does. I will add P53 because it corroborates with the CK20 staining, but it's not always helpful.
The next question is, for micropapillary urothelial carcinoma, is HER2 stain done on immuno or FISH? On immuno, do you just say positive, negative, or you do a scoring?
So for HER2 new on immunos, we follow the same process as we do for breast cancer. And if it's unequivocal, we report it out. If it's equivocal, we defer it to FISH testing, and we report the FISH results.
The next question I can see is, how can we differentiate histologically an invasive urothelial carcinoma from a non-invasive carcinoma?
So the key thing is, you have to, if it's a TURB specimen or a biopsy, you have to look at this. You have to look for single cells within the lamina propria. So in the bladder papillary cancers, you have to look at the cross section of a papillary core, and within the lamina propria, you have to look for single cells. The single cells will often have cytoplasm, which is large, which is more pink. So we call that paradoxical differentiation. We can also, as an aid, use a pan-cytokeratin marker, which highlights the single cell in the lamina propria. I mean, this is also true for not only invasion in the lamina propria, but oftentimes when you're trying to assess the prostatic stroma, and you are looking to see if the in situ cancer is in the stroma of the prostate, pan-cytokeratin stain like AE1, AE3 is very helpful in that context.
Next question I see is that does the radiological and cystoscopic findings aid in a TURBT space?
Yeah, absolutely. So every case that I sign out, so I'm on GU service today, for example, I have 5 bladder cases to review. If I have a resident with me, he or she will preview the cystoscopy report and look for what did they see cystoscopy, because you can have a bland papillary inverted growth pattern within a bladder lesion which looks very bland. But if the cystoscopy report suggested a papillary tumor, which is exophytic, I will do a deeper section. I will look for any evidence of a papillary tumor. So cystoscopy and radiological and imaging findings and this urologist impression is very critical in making the diagnosis. So I don't make the diagnosis in silo. I always correlate it with cystoscopic findings.
Rima from Syria has this question for you. So she wants to know regarding paraganglioma. So do we always recognize that eosinophilic material in the cytoplasm so we can consider it the clue, or are there any other clues?
So it's not always seen. It depends on the lab preparations. It depends on the H&E stain. It's not always clearly evident. But if I see a very unusual nested pattern, I don't see a lot of mitoses, I don't see a lot of atypia, I question myself. I stop, I pause, and I wonder, could this be a paraganglioma? So that eosinophilic material is not always seen. It's seen, I would say, in 50% of the cases.
Another question that I can see is, please illustrate an immunohistochemical panel for molecular classification of bladder cancer.
So I think the key markers are CK20. The other key markers are P53. You even use CD44S and look for its loss, because some of the tumors which is CK20, basaloid, more luminal patterns, you can kind of separate them out. But if you look at it clearly, it's a transitional diagnosis, because it's a spectrum, right? It's a spectrum of morphological appearance. Even within a case which clearly looks squamous, you will occasionally see cells which look more non-squamous. So I would not be confident that I can use a panel of immunomarkers and subclassify these tumors in a molecular subtype or not. But we can use some of these as guidelines, CK20 staining, CD44S, P53, because clearly we can see the correlate. I have used P16 as a surrogate. I've used RB as a surrogate in the past. So deep down, you are dealing with a patient who has a spectrum, and we can present at any point in the spectrum.
Right. There is another question. What do you do when we see an invasive component in papillary lesion? Should we sign out as high-grade papillary urothelial carcinoma or invasive urothelial carcinoma?
So I would sign it out as invasive ureteral carcinoma, because that tells the urologist that this patient is now moved beyond a papillary pattern into an invasive pattern. So they have gone down into the pathway of RB and P16, where all these tumor cells have gone through a neoplastic progression into this pathway. So even if I see one invasive cell, I call it invasive urothelial carcinoma. I let go of the papillary terminology, because that's the worst outcome that the patient will have. and should be treated appropriately.
So Dr. Gunjan Agarwal wants to know, is there any way to differentiate lymphatic invasion from retraction artifact on H&E?
So practically speaking, it doesn't really matter because 2/3 of the patients in a micropapillary who have a micropapillary pattern will have lymphatic lymph node mats. But occasionally, in a rare, when there's only 1 or 2 cells, you can do CD31 or you can do a vascular marker and you can see, is this what you're calling a retraction artifact? Does it have any endothelial cells or not? So I rarely use it because in the context of a micropapillary variant.
So Hina has this question for you, that what is your diagnostic criteria for pun lump, as she finds it very confusing.
So I find it very confusing too. So I rarely make the diagnosis. Urologists don't really care about it. So the best practical thing is to either call it a papilloma, which is very easy to separate from a carcinoma. I occasionally will make the diagnosis where I want to call it a carcinoma, but the patient is very young and I don't see a lot of mitosis. I don't see a lot of solid growth pattern. I don't see a lot of complexity in the architecture. And then I will make the diagnosis. But routinely, I will either call it a papilloma or a carcinoma.
She has another question for you, that if a biopsy has a small cell carcinoma along with conventional urothelial carcinoma, how would you report it?
So in that setting, I will routinely call it invasive urothelial carcinoma with the following subtypes: NOS 50%, small cell carcinoma 20%, sarcomatoid 30%. So I usually quantitate the individual components because that's very helpful to the urologist and to the oncologist.
All right, I think this might be the last question, that if we detect incidental prostate acinar adenocarcinoma in a resection specimen of bladder with prostate taken out for bladder cancer, do we need to regross the prostate and quantitate the tumor?
So we don't routinely do it because most of the time it's an incidental finding, and we have a process where we submit about 6 sections of the prostate. We don't go back. The only setting that we would go back is if it's high grade, if it's like greater than 3+4. We'll go back and sample more of the prostate to see, if you're missing a really high grade cancer, which could require patient to come back for additional prostate cancer therapy or treatment or radiation, whatever. But routinely we don't, because most of the incidental prostate adenocarcinomas are low grade.
I think that's it for today, for the questions online that I could find. And once again, thank you so much, Dr. Parwani, for taking your time and presenting such an excellent lecture and explaining so many different aspects of urothelial neoplasms. And you would be so happy to know that we had 1,000 viewers at least from so many different countries. And in fact, I could count at least 30 countries worldwide who joined live, and we had viewers all the way from Brazil, Nigeria, Bolivia, Singapore, Sudan, Guatemala, Bangladesh. Of course, we had viewers from US and as well as from India. And thanks to all of our viewers for joining in and supporting us. Hope you all stay safe. And as always, if you like our lectures, please subscribe to the YouTube channel, that is Patcast, and also follow and like our Facebook page. So in that case, you would stay updated and informed about all the upcoming lectures. In fact, we have The next podcast coming up, that is on May 8th, that is Friday at 8 a.m. Eastern Time. So Dr. Daniela Allende from the Cleveland Clinic will present a GI PET lecture on pattern-based approach to non-IBD colitis. So see you all then. And thank you again, Dr. Parwani.
Thank you. It was a pleasure to be here.
Thank you. It was a pleasure to be here.